Indian as having osteoporosis if you were to use a Caucasian database. So, for instance, and Sri Lanka is pretty much Indian. Yeah.
I'm sorry to be interrupting you. I think it will be quite important to be able to know what adjustment factor can be applied, because I mean, after all, in Australia, there are
we don't have that kind of studies though to kind of show exactly how much, I mean, and all that. But I'll just try and say, I'm sure. I think on what's the DEXA machine, which I don't want to end up having this whole conversation centered around it. I'm sorry. I mean, I didn't mean to kind of make you go down the rabbit hole too. But what's the machine that was used, Dr. Quinn? Was it Hologic?
I think her internet actually dropped out and she can't unmute herself on her phone.
Oh, okay. Because, I mean, I'm not sure, because mine is a Hologic machine, so I'm not sure. But in Hologic, you can kind of change the normative base, at least kind of put Asian and see, I would suggest trying to put Asian and seeing. Because in Singapore, we have ethnic specific. We have Indian, we have Chinese, and we have Malay. But if you don't have that on your Hologic, on DEXA machine, I think for sure there should be Asian, and just play around with it. Not that I'm saying that it is, I mean, it's absolutely because of that, but it's worthwhile, looking at it to see what differences you get.
Okay. Thank you for that. Does anyone else have any other comments? Oh, Quinn is back.
Yeah. Yeah, that's something we can look into.
Yeah.
Does anyone have any last comments they want to add to the case?
Would anybody recommend that we do treat with an anti-resorptive?
Not now.
No, I don't think so. I think we really need to try to establish
what's going on. Yeah.
Whether there was any eating disorder, for instance, and all the other things.
Yeah.
I think
I also would.
There's a remote possibility that he's actually got an inflammatory bowel disease, which can be complicated by spinal inflammatory joint disease as well. I know he had an endoscopy, which didn't show anything, but I suppose the question is theoretically, at least there, and whether he's having some form of malabsorption. So his nutritional aspects and everything else, I think, are well worth looking into.
So many kilograms of weight loss, definitely that needs to be kind of looked in. And you said it's unintentional, so I agree with Gabor. Yeah.
Right.
Perhaps Quinn can...
and controlling his disease, obviously, is important in overall control too. So.
Perhaps Quinn can give us an update in a couple of months' time on the repeat bone density and his progress and any further investigations.
Thank you very much.
Okay. So our next case will be presented anonymously, and this case highlights the challenges of recurrent fractures while on treatment. So I'll just share my screen. So this is an 87-year-old woman who was diagnosed with postmenopausal osteoporosis at the age of 60 in 1997. She was treated with alendronate for about 12 years. And at the time of initial review with the endocrinologist in 2017, she had been off treatment for about 6 to 7 years. Her only fracture history included a right-sided atraumatic metatarsal fracture in 2017. But prior to that, she had no other fractures. Her past medical history includes gastroesophageal reflux disease, asthma since childhood, and rheumatoid arthritis. Over the years, she's had a couple of flares requiring steroids for several weeks at a time. And between 2009 and 2017, she had roughly 4 courses of prednisone. She had menarche at 12 to 13 years of age, 4 children who she breastfed for 3 to 4 months at a time, and transitioned through menopause in her late 40s with no hormone treatment. Her family history included maternal history of osteoporosis, and her daughter also has hyperparathyroidism, although it's not clear whether it's primary. Socially, she's a non-smoker. She drinks about 4 to 5 standards of alcohol per week. Her BMI is 24. She's otherwise independent with good mobility, does a lot of walking day to day. She has low dietary calcium intake, but overall eats well. So at the initial review in 2017, she had a DEXA bone density performed. The L1 to L4 T-score was -2.7. Left femoral neck T-score was -3. Left total hip T-score was -2.2. And in the right forearm, the T-score was -5.6. So after this review, she was commenced on risendronate 35 milligrams weekly. About a year later, she had a repeat bone density, which showed an improvement, particularly in the lumbar spine and the total hip, and I guess stable / maybe a decline in the right forearm, although that's not a good marker of progress. However, at this point, she had persistently elevated bone turnover markers, and she was changed to intravenous aclaster. The dose was actually delayed for a couple of months by the patient, and during this period of time, the patient sustained an L1 fracture during a twisting motion, changing a vacuum bag. About 8 months after her zoledronic acid or aclaster, she had a repeat bone density scan, which again showed very stable T-scores in the hips, but perhaps an improvement in the lumbar spine, or I'm not sure the degree of degenerative changes. Her bone turnover markers at the end of the year, 12 months after aclaster, was still suppressed, so the second dose of aclaster was deferred. In April 2021, again, her bone density was repeated. The lumbar spine bone density had decreased, but everywhere else was quite stable. She then had a second dose of aclaster in May 2021, and a repeat bone density the following year. She was then started on romosozumab or Evenity in August 2022 and completed the course in July 2023. And these are her bone density measurements after completion of romosozumab. Overall, I believe there was the T-score in the lumbar spine improved from -1.7 to -1.4. The T-score in the left femoral neck improved from -3 to -2.4. And in the total hip, it was stable at -2. Following her consolidation with intravenous aclaster again, she then sustained multiple vertebral fractures. In May 2024, she had a T11 fracture, and in July 2024, just 2 months later, there was a 60% loss of height at the T9 level and a complete compression fracture of the pre-existing T11 fracture that we knew from before. So the questions from the clinician are, the patient is attending review next week after discharge from hospital following these fractures. What should she have done differently? Was she missing anything? And what should be the next steps in treatment? So overall, this is an 87-year-old woman who has had 7 years of treatment now, including anti-resorptive and romosozumab, with relatively low bone densities and recurrent fractures. So starting with Catherine, do you think anything could have done differently?
I don't think anything needed to be done differently. I guess when you're giving romosozumab after a lot of intravenous zoledronic acid, you might have bunching of the anabolic response, although perhaps that would be more the case with denosumab. I am concerned that despite this treatment, she's had very significant vertebral fractures with T9 60% loss of height, T11 fracture as well. So I think we need to look hard for either for skeletal malignancy or for myelomatous process. So I'd start by doing that secondary screen, looking at the light chains and a EPG. But I'd also have a low threshold to doing a CT skeletal survey plus or minus a bone scan.
Yeah, thank you. Gabor, is there anything else you would suggest as part of the secondary screen?
No, Brenda, thank you. I think the woman's been well managed. And I agree with Catherine with checking for myeloma is appropriate. I think the likelihood is probably small, but certainly worth a go. Apart from that, what will I do from here on in? I guess was the other question that I saw there.
Mm-hmm.
And I think it's really a very good illustration about the problems that we've come to recognize with denosumab, about the off-ramp issues, when you stop it and so forth, or the problems that come up. I think
I'm not sure. I'm not
you don't
sure
want to talk about
she
that
was
yet?
on denosumab. I think she just had
No.
alendronate.
I wasn't, sorry, Brenda, I wasn't referring to that. I was referring to the potential problems. She's hasn't had denosumab. And I guess there could be an argument that denosumab would be a more effective anti-resorptive than the ones that she's had. So I was alluding to the problem about the decision to put her onto denosumab at this point. So in a younger person, would be quite concerned about starting denosumab because of the issues about stopping. But she's now 87, I think.
87.
I guess the idea of continuing to the end of her expected life is not such a big ask.
Exactly.
And I suppose I would be at least entertaining the idea of swapping her to Prolia, having a chat to them about it all. But obviously it's an open question. But no difference in the way it had been handled up till now.
Okay, thank you for that. I guess the other question, Manju, is I know we've already talked about the possibility of changing to denosumab. Do you think there's a role for using another anabolic agent such as teriparatide in this case?
Yeah, no, I completely agree so far what Catherine and Gabor have said in this case. Really, I would also just make sure, though the likelihood is unlikely. I mean, her renal function is okay. I mean, she really didn't have anything, but with the big drop in the spine, BMD, and the fractures, you are obliged to make sure that she doesn't have a disease process like multiple myeloma, though I think it is unlikely. But I would also do that, and definitely post Romo, it has to be followed up by another agent, and based on the the frame study, and it's denosumab, and like Gabor said, I would continue on it for the she's 87 years old. I would continue her on it for the rest of her life. Whether or not teriparatide is indicated, I mean, she did okay on Romo. Do we have post-Romo DEXA scans? And, she hasn't had any other fractures after the 1 year of Romo, right? When were the fractures?
Sorry,
Was it after, while on Romo?
Yeah. No, it was after. So she completed Romo in July 2022, and then had... No, sorry, July 2023, and then had a cluster in August 2023, and then less than a year later, she had the vertebral fractures.
Yeah, I mean, okay. She had IVF cluster in August 2023. There's so many kind of things. Yeah. So your question was, I mean, I would switch to denosumab, but your question was, I mean, we don't have any data. I mean, there is some data to show that, Romo followed with some very early studies kind of showing that Romo followed by alendronate, is a possible, followed by teriparatide, could be tried, but that's really pretty much of an evidence-free zone. I don't see why I would not. I don't see any active contraindication to it. And right now at this point is basically just throwing whatever we have at her because she's continuing to fracture. So I would either go with switching to denosumab or worth a try giving her 1 or 2 years of teriparatide. I don't know what your Australian kind of reimbursement kind of criteria and all that. I mean, I don't see any, no hard and fast kind of thing. If teriparatide is available, and given that she's had such a drop in spine, it is in the spine that she suffered the fractures and all that, teriparatide does, its effect on the spine is pretty good. So 1 or 2 years of teriparatide, should be okay. I mean, I don't see any reason why she should not get it. Yeah. And maybe it might be a little bit better. And then after the teriparatide, then you can switch her to denosumab.
Yeah.
I mean, but either going straight to denosumab is also not a issue. But in Singapore, it would be an issue because, I mean, people pay out of pocket for the teriparatide. So the cost issues would be quite considerable. But if you don't have that problem, then 1 or 2 years of teriparatide, get her bone density even further higher up. Remember that though, because she's gotten that IV zoledronic acid, maybe there might be a lag time before her BMD starts improving when you switch to teriparatide. But like Kathy mentioned, it is not as bad as switching from denosumab to teriparatide. Yeah.
I think we need to be very careful that she doesn't have any skeletal malignancy before we fuel the fire with an anabolic.
Exactly. Very good point. Very good point. Yeah. So the multiple myeloma, the CT, make sure that she doesn't have any skeletal malignancy. Very good point. Yeah.
Yeah. We have one comment from the audience about whether the Romo was privately funded. I'm not entirely sure, but I guess she did technically have this L1 fracture in 2018 while on Actinol and or before the dose of aclaster. So she might have qualified on the PBS back then. I'm not entirely sure. All right, and just one last question, Catherine, to play devil's advocate, if the patient has another fracture on treatment after we change it over to denosumab or even teriparatide, if she's appropriate for that, what would your options be then?
Well, I think based on the data switch study, the best combination would be the denosumab with the teriparatide and then continuing the denosumab lifelong after that, assuming we've excluded malignancy.
Yeah, I would agree.
Yeah.
And I'm just one fracture, and I've also to kind of, just to kind of again put things in perspective, just having one fracture while on treatment doesn't necessarily constitute treatment failure. So your theoretical question, Brenda. So that must be kept in mind. But yeah, the combination, the switches, the transition, the sequence is always best anabolic followed by anti-resorptive. And definitely with the data from the data switch trial, denosumab followed by teriparatide is a bad idea because it causes a decrease in total hip and lumbar spine BMD. But the total hip BMD takes about 1.5 years for it to kind of come back to creep up to back to where it was. And the forearm BMD actually continues to go down. So that kind of sequence is definitely not recommended. But you could, sometimes we add on, to the denosumab based on kind of extrapolating the data from the data trial. We can add on to teriparatide to denosumab, but definitely not switch from denosumab to teriparatide.
Could I just very briefly add that, not as a recommendation, but just as a comment, that a second year of ramucirumab has been evaluated and has been shown to be well done.
Exactly. Yeah.
So I guess that's another possible
option
to consider.
Okay. Very good. Does anyone else have any last comments before we move on to the case vignettes, which actually follows from this case quite nicely? Okay. All right. So I'll just bring up the slides for the case vignette. Sorry, we just got one comment. Caroline from the audience asked, can you please add the data behind using a second year of Romo?
Yeah, I can put it in, while we are talking the third case, I can pull up that,
Yeah, I can't find the reference for it, but
yeah, I'll see if I can get it and I put it in the chat box. I think it was presented at ASBMR. I'm not sure that it has been published yet, but I'll see whether I can find it and I'll put it up in the chat box.
Okay, all right. Thanks, Manju, for that. And Gabor, what were you saying? Sorry.
Much the same. Much the same. Yeah. Just put the reference in the question to Google and you'll get the reference in a couple of minutes.
Okay. All
Yeah.
right. I'll wait eagerly for that. So, our first of two case vignettes is a similar story. It's a 75-year-old woman who was diagnosed with osteoporosis while living in Lebanon almost 20 years ago. So unfortunately, some of the information about her treatment over the years is not complete. But our understanding is she was treated with weekly oral bisphosphonates for many years. And then due to no improvement in her bone density, she was changed to intravenous zoledronic acid annually for a few years, and then eventually changed to denosumab a few years ago, primarily due to convenience. And she has confirmed compliance with denosumab, which she is receiving regularly and on time. She's had 2 falls in the last 2 years. And in terms of a fracture history, in 2019, she had a bone scan demonstrating an old L2 crush fracture with 40% loss of height. In 2023, presumably when she was on denosumab, she had another bone scan demonstrating a subacute L4 fracture with 30% loss of height, T12 fractures with 90% loss of height, and 2 rib fractures. She had a CT lumbosacral spine, which again illustrated the fractures as described, as well as evidence of generalized osteopenia. She started seeing a new GP who then referred her to the endocrinologist for concerns over ongoing vertebral fractures while on treatment. Her latest bone density in January 2024 demonstrated lumbar spine L1 to L4 T-scores of plus 0.2. In the right total hip, I believe, it was minus 0.4. In the right femoral neck, it was minus 1.3. In the left proximal femur, it was plus 0.6. And in the left femoral neck, it was plus 0.4. Unfortunately, the older DEXA scans historically were not available, and there are no machines in the nearby area that could do QCT. The patient has inadequate dietary and calcium intake, as well as I think she's on supplemental calcium intake, and her vitamin D level is replete at 61 nanomoles per liter, but her other secondary osteoporosis screen was unremarkable. She had dental implants 8 years ago while on anti-resorptive treatment, and there were no issues with that. She doesn't have any history of myocardial infarction or previous strokes, and no risk factors for cardiovascular disease apart from age and hypertension. So the question from the clinician is whether we continue the current therapy with denosumab, or whether we can add on romosozumab or teriparatide. The patient is happy to pay for osteoanabolic agents because she does not qualify in Australia based on her DEXA scores. So, Manju, what are your thoughts about this case?
Okay, just curious. I mean, so what is the Australian, Australian criteria? I mean, so irrespective of whether the person is fracturing left, right, and center, it's still based on the bone density, is that
Yes.
you qualify for an
So currently, in order to qualify for either romosozumab or teriparatide, you need to have at least 2 fragility fractures, one of which sustained on adequate treatment of at least 12 months, as well as a lowest T-score of less than -3.
It's odd. So she does qualify, doesn't she? I mean, you know, this is, I know, digressing from the main topic, which I'll come back to, but doesn't she qualify with the 30% height loss, which is a grade 2 fracture, and the T12 fracture, which is a 90% height loss, and the rib fractures? This is not considered as fragility fractures?
No, she qualifies for that part, but she won't qualify for the other part, which is a T score.
Oh, it is and.
-3. It is.
And
Yeah.
oh my God, seriously, wow. Okay.
Although there are new, possibly new PBS criterias coming out for romosozumab, maybe in November.
Oh, really?
no
Okay, yeah,
full
that's
NDA.
unfortunate. I mean, yeah, no. So I mean, given the fact that on denosumab, she's had all these new fractures or worsening fractures. What do you call it? I would, but and like we've been mentioning, I mean, from denosumab switching to teriparatide is not a good idea based on the data that we have. I would either add teriparatide again. Like I said, that's kind of really mangling the data study. Okay, in the data study, both denosumab and teriparatide were started together. Okay, this is saying whenever we talk about this kind of off the label add-on teriparatide that we are talking about, it is not really what was done in the data study, because here the person has been on denosumab for many years, so we don't know whether adding on teriparatide is going to be the same effect as what was found in the data study, where the combination definitely had better BMD outcomes. We don't have any fracture data, but still, given that, I would either add on teriparatide or Romo, because the increase in BMD and you still get fracture reduction with Romo. When denosumab is followed by romosozumab, the gain in BMD, though it's not as good as when Romo started naive, you still do get an increase in BMD and there's fracture reduction data. So I would either go with adding on teriparatide or switching to romosozumab.
Okay, thank you. Gabor, at the moment, how do you time sort of the commencement of romosozumab or teriparatide in relation to the last dose of denosumab?
To be honest, I would take a different approach to this patient. I would first of all again look for, as previously mentioned, other explanations for those vertebral fractures, rule out malignancy and so forth.
Yeah.
Having done that, my inclination would be just to continue on. I don't really feel attracted to the idea of giving anabolic agents on top of what she's already achieving. For the various reasons, given I think that teriparatide switch is a risk. The romosozumab would not be such a risk, but there is a significant cost associated with it. So I just don't feel sort of compelled that there's a strong argument beyond continuing existing treatment.
She said multiple new fractures while on treatment, right? Though,
Yeah.
I mean, for sure the secondary that's given though, Brenda. I mean, I would like to add that I mean, I was answering specifically your question about therapy. I completely agree with Gabor that the first and foremost cardinal rule is that make sure that no other new secondary contributors have popped up. That's done. I mean, that's a done deal kind of thing.
Yeah, the clinician did say the secondary screen was unremarkable.
Yeah, so I mean that's for sure you must do. But I don't know. I mean, given that she said 4 new fractures, on denosumab, I think it'll be pretty hard to and there's no point looking at the T-scores because the T-scores are pretty normal, right? I mean, so following her BMD doesn't seem to be a good idea. So clinically the fact that she's had so many fractures while on denosumab, I would think that, you should possibly consider another agent. And, so that's why I said add on teriparatide or switch to Romo.
Well, perhaps that's just to build up on the picture. One could look at resorption markers and so forth to see how they're behaving. But if the resorption markers are giving a similar story to the BMDs, I would be happy to sit where I am.
Yeah. Catherine, would you continue the current therapy or would you think about changing over to anabolic treatment? And I guess a follow-up question to what Manju and Gabor have said is, about the T-scores not being very low. Is there data to say that anabolics are particularly effective in patients with very mild osteopenic T-scores or even normal?
Look, I don't think we can say this patient has osteopenia. The patient's elderly and presumably has a lot of degenerative disease in the spine. So in an ideal world, we would like to see a lumbar spine QCT. It could be useful to look at the distal radius bone density. That may give us more information. Also, looking at bone turnover markers, I think, would be helpful. I think we can be reasonably confident there's no skeletal malignancy because the patient's had a CT as well as a bone scan in the lumbosacral spine. You know, any sort of lytic process or sclerotic lesion would have shown up on that imaging. So, I mean, we'll check an EPG and so on, but I'm fairly confident that if we've done that, we're not looking at an underlying malignancy. And I think the best data is to use the denosumab in combination with the teriparatide. And even if she doesn't qualify under the PBS, it's quite reasonably priced now that it's off patent at about $170 a month. So that would be my approach. I think that if you try to use Romo after the denosumab, you're going to have a very blunted bone density response.
Would you start the teriparatide at the same time that denosumab is due and just continue denosumab?
Yeah. Just keep going.
The normal bone density is not just in the lumbar spine, which, as you said, could be distorted by osteoarthritis, but also in the femur.
That's why I'd like more information. I'd like to know about the radius because it seems a bit incongruent.
Well, the femur is also normal. They're both.
I know the theme is normal, so something doesn't make sense here. That's why I'd like to know the QCT and the distal radius T-score.
And if they're still okay, would you still want to add
but
an
she's
anabolic?
showing that she has no fractures. So.
Look, they're very significant fractures. She's had 90%
Yeah,
loss of vertebral
exactly,
height at one of those vertebral
exactly.
bodies. So I don't think that you've got a lot to lose by giving her teriparatide. And I think we need to be pragmatic in this sort of situation.
Yeah, I agree that, those fractures are not trivial. And, I mean, I think there is no point to kind of just follow up. I mean, we sometimes see this, normal looking bone density for whatever reason, but, patient has fragility, bone fragility, as evidenced by she's showing you clearly that she has got skeletal fragility with these multiple vertebral fractures. So I agree with Catherine. But Romo, adding on teriparatide, like I said, in Singapore, we would either, I would either add teriparatide, which, patients kind of balk at. They don't like the concept of daily injections. Asian women in particular, they're quite reluctant. They'll do it. And then, of course, we're paying out of pocket. But, and as I clearly mentioned, the BMD gains that you see when romosozumab is started naive is definitely better, but compared to teriparatide given after denosumab, where there is a clear decrease that you see with Romo after denosumab, though you don't get as much gains as it would where if it was treatment naive, you still get improvements in BMD and a possible fracture reduction. So either adding on teriparatide and like what we said, the next dose of denosumab at the same time start off teriparatide or switching to Romo. I would definitely do that after ruling out any other secondary contributors. So she's clearly showing you that she has skeletal fragility. Irrespective of what her bone density is.
I had just make a comment as well. A highly effective combination of teriparatide and that denosumab was in treatment-naive patients.
Yeah, exactly. That's what I said.
This is not the same situation here.
Exactly. It
is.
is.
Addition. So
yeah.
I'm not aware of any strong data to sort of address that situation.
Yeah. There isn't, but we are doing it like Kathy said it's a more of a pragmatic kind of thing. Like I clearly said, the data study in which teriparatide and denosumab were started, combination therapy, teriparatide and denosumab was, both of them were started together at the same time. And this lady has been on
very
denosumab for
different.
many years. Yeah.
Does anyone in the audience have any questions or comments they'd like to add? I guess while we're waiting for that, if we were to change over to romosozumab, what would be the suggested timing? Would you give romosozumab 4 months after the last denosumab dose, 6 months after the last denosumab dose?
6 months after the last denosumab, just like you just switch, so you just switch. I mean, you were saying that, okay, if the denosumab dose, I mean, would I wait for another 6 months, before switch? When was the last denosumab dose in this lady? That might be useful to kind of know.
I'm not too sure.
I mean, there is a theoretical kind of thing in which, I mean, it might be because romosozumab has got a dual action in that it increases bone formation and decreases bone resorption. Theoretical, there's no data to show, there's no data for it. The study in which Romo was given after denosumab was 6 months after the last denosumab dose, but maybe there might be a grounds for kind of saying while the bone turnover markers are still not suppressed down to like undetectable levels, giving Romo might be a better option, but we don't have the data for that. So yeah.
Okay. Thank you for that. We just have one question. If the denosumab is not due, say, for another 4 or 5 months, would you start teriparatide now and just give the next denosumab dose as planned? Or would you wait until the 4 to 5 months mark when denosumab is due to then start the teriparatide?
Sorry, what is that again? Why do you wait until the next denosumab dose to start teriparatide? Because, I mean, if there is bone turn, again, this is this theoretical thing, but we don't know. I mean, the bone turnover markers, if they're still, the reason why giving teriparatide after denosumab is a bad idea, the postulate is that, there is a pool of dormant osteoclasts, which get, kind of, when teriparatide is given, it gets sucked up, I mean, and, kind of, and, thrown out into the circulation again, because teriparatide increases bone turnover. So that is why theoretically, if at all you're giving it, I would kind of give it, together with the next dose of denosumab, rather than give it some way halfway through, because, all these, the semi-recumbent osteoclasts might get, super activated again. But this is again all kind of, splitting hairs really. I think wait for the next dose of, the denosumab, and give the denosumab and give the teriparatide at the same time.
Catherine, in your practice, once you start someone on romosozumab, when do you then consolidate with denosumab? Is it a month after the last romosozumab dose at the same time, or there's no particular evidence to guide it?
I don't know that we've got evidence to guide it, but I generally do it 1 to 2 months after the last dose.
Yeah, I do too.
And I guess during this time, how frequently would you be monitoring the bone turnover markers?
I'd probably do them 6 months after a change in therapy.
Okay. Gabor, do you have any final comments you want to make, or anything else you want to add?
No, I don't have anything to add. No, I think I've said all I want to say.
Okay, thank you. So that obviously was a very interesting case and prompted a lot of interesting discussion. Our next case is a little bit different. Let me just move on. Okay, so this is a 23-year-old woman with a minimal trauma right sixth rib fracture that was diagnosed in June of 2023 after some coughing. And there was some issues with delayed healing. Her weight is 54 kilograms, her BMI is 19.1. She has a history of suboptimal calcium intake, as well as mild hyperprolactinemia in the context of a Rathke's cleft cyst that is being monitored by the neurosurgeon. Due to the hyperprolactinemia, she was started on carbergoline and slowly increased over the years. There were no other identifiable risk factors, and her secondary osteoporosis screening was satisfactory, including her tryptase level. She is known to a gastroenterologist due to a history of gastrointestinal dysautonomia, as well as gastroparesis, which is thought to be due to Ehlers-Danlos syndrome and POTS. She is on regular domperidone as a result, which she has good effect from, and that is taken in combination with the carbergoline. She also saw a hematologist for elevated CD3, CD4, and CD8 counts, but her tryptase levels, ACE, and autoimmune screen was unremarkable, and the hematologist thought the changes were more reactive and was not too concerned. So the patient had a bone density performed in June 2023 with a Z score of -1.5 in the lumbar spine, -1.2 in the hip, and -0.7 in the left wrist. The patient herself is not keen for any particular pharmacological management, and she wants to start a family. The question from the clinician is whether it's reasonable to continue monitoring this patient and whether there are any specific considerations for her future pregnancy and postpartum care. So Gabor, are there any other details you'd like to know from this case?
Yes, thank you. I just almost missed it, but I think you said that she's got Ehlers-Danlos. Is that right? She's got joint hypermobility.
I think that was diagnosed as part of the gastroparesis, but I don't know the details of how it was actually diagnosed or confirmed.
Well, I think it would be an interesting question to delve into, because these people do have an increased fracture risk due to osteogenesis imperfecta related problems. So I guess that could be a factor. But the cough fracture itself, I don't think that I would not regard that as a trigger for starting treatment. I think people suffer cough fractures, which are, if you like, innocent. So akin to getting stress fractures or marching fractures in the feet when you go on a long walk. So I wouldn't say that as a trigger for starting treatment. But in relation to her history, I guess I would be interested to know if there was any genuine evidence of Ehlers-Danlos.
Yeah, that's a good point. Catherine, what are your thoughts on this case?
So I'm interested in the hyperprolactinemia. Do we think it was simply caused by the domperidone, or is it actually due to a pituitary abnormality? Also, is it biologically significant? Did she have galactorrhea or any disturbance of her menstrual cycle? I think in looking at her risk of fracture, her estrogen status is critically important.
Yes, so I do have a bit more information about that. So the patient had menarche at 14 years of age, initially quite regular menstrual cycles, but then developed dysmenorrhea and menorrhagia. And she was started on the oral contraceptive pill in 2018, which is ongoing, and she has bi-monthly withdrawal bleeds. I believe the prolactin level was being monitored as part of surveillance for the Rathke's cleft cyst. Initially, it was normal, but it did start rising even, I think, up to a level of 1,180. And there was a macroprolactin component to it, but even after they excluded that, the monoprolactin was still elevated at 656. This was prior to the commencement of domperidone, and given the patient, gastroenterologist had the plan to start domperidone, that was I guess, the reason for commencing carbergoline. I think around that point, there was a small increase in the cystic pituitary lesion and maybe some very mild visual field loss as well. And after starting the carbergoline, the prolactin level mostly stabilized and the visual field loss resolved.
So you think there was some stalk compression from the Rathie's cleft cyst?
I'm not 100% sure. I wasn't sent any of the imaging.
Mhm.
But yeah, I guess with the mildly low, not too high levels of prolactin, that's probably the cause. Although I guess with the cystic pituitary lesion, it was about 10 millimeters.
Yeah. Do you think the cabergoline's going to be less useful if it's stalk compression as opposed to a prolactinoma?
Yeah.
I mean, especially if the patient's on the oral contraceptive pill, I'm not sure that I would have rushed into treatment with a dopamine agonist. I'm not sure what we're achieving there. In terms of the fracture, I agree with Gabor. I don't think it's a major osteoporotic fragility type fracture. I'm not too concerned about that. The T-scores are only minimally low. The patient wants to have a family. I certainly wouldn't be starting her on an anti-resorptive bisphosphonate type drug. I think that just trying to ensure that she has normal estrogen status, vitamin D and calcium intake is the way to go.
Yep. Manju,
Completely agree.
Yeah, how would you counsel the patient regarding her pregnancy and postpartum care?
I would completely agree with Gabor and Catherine on this. I'm not unduly concerned about that fracture kind of thing. And as far at least right now, the DEXA is normal. I mean, her Z-scores are within the expected range for age. I would not call her, she's only 23 years old. I would not call her as having even low. And like I said, again, osteoporosis, you're not supposed to make the diagnosis of osteoporosis based on T-scores in these young people. Her Z-scores actually are within the expected range for age. She does not have low BMD. I would go with, just regular, but that said, the hyperprolactinemia may be, a cause for hyperprolactinemia is associated with low BMD and increased fracture risk. But I would not let that preclude from saying that, she can go ahead with, pregnancy and all that. But obviously all the other measures, ensure good calcium vitamin D intake, weight-bearing exercise, etc. And, we could check her, monitor her BMD just to make sure that it's not dropping. And I'm also interested in this thing which Kathy brought up, whether, whether this, the Rathke's cleft cyst and the hyperprolactinemia, if it is due to stalk effect, whether it would respond to cabergoline as much as it would from, like a proper prolactinoma. I'm not, I don't think it will. I'm not sure. I'm sorry, did I miss something? I mean, did you say that the prolactin levels have come down to normal now on the cabergoline or?
I believe they did come
Okay,
down.
so maybe, yeah. So, yeah, but I would not be, the prolactinemia, I mean, and obviously the cabergoline and all that is a separate counseling altogether. But as far as her BMD and, and all that is concerned, I'm not going to tell her, oh, this pregnancy and postpartum and all that are big issues, because the BMD is normal now anyway.
Yep. Would you say anything particular about the duration of breastfeeding, or would you just let her do what she?
Yeah, just let her do what she wants. I mean, let her do what she wants. I mean, yeah, so nothing, no specific contraindication there at all, because the BMD is normal. I would keep an eye, based on the prolactin levels, because that is hyperprolactinemia is definitely associated with the low BMD and a fracture risk. Yeah, that's it really. Somebody's asked a question, why is it's just one rib fracture, yes, but and that could be again the hyperprolactinemia issue is simmering there, and whether that is a cause for the the rib fracture is kind of must be kept in mind. But I don't think at this point in time we have to jump all over her. And, if she continues to fracture, then there is a different question altogether, irrespective of what her BMD is. We have to, and then there comes Gabor's point about making sure that she doesn't have any other than the hyperprolactinemia, other, genetic causes like OI and all that, which may need to be concerned. But I don't know whether just based on one rib fracture, I would kind of extensively work up. No, I would not. Yeah. Brenda, I'm so sorry. I really have to go, but I'm so sorry because I'm running a few minutes late, in fact. But thank you so much, and I'll have to leave right now.
No problems at all. Thank you for your time this evening.
Thank you. Wonderful cases. Lovely seeing you, Kathy and Gabor. Bye.
Bye. We just have a couple more endocrine specific questions. So maybe I'll ask Catherine. Does the use of the oral contraceptive pill in teenagers have an effect on the bone density and the peak bone mass that can be achieved?
Look, I think the data's a bit mixed in that regard. We always do have some concerns that oral estrogen can suppress hepatic production of IGF-1, but I don't think there's any conclusive data from the literature about that. It's just something, we keep in the back of our minds.
Okay. And one more question. If the patient didn't have any amenorrhea, could the mildly elevated prolactin level be related to a low BMD?
My understanding was that the effect of hyperprolactinemia on bone density was mediated through estrogen deficiency, but I'll have to have a look at the literature as to whether there's any independent effects that are not mediated by estrogen deficiency.
Yeah, okay. And just one more question for Gabor. You mentioned that Ehlers-Danlos loss increases your risk of fractures and low bone density. Are there any particular patterns to the fractures? Is it your general osteoporotic fractures like in your spine, in your hip, or do you tend to get more distal, smaller fractures?
No, I think these people are different from osteoporosis. Yeah, if anything, it's like osteogenesis imperfecta. So they're an abnormal bone composition, if you like, that underpins it all. The fact that they've got what's the name? Joint hyperextensibility with some risk of dislocations and so forth, which is sorry.
Oh, I think she just muted herself. Yes, sorry, continue.
Okay, so it puts them at risk of dislocations, sprains, and so forth. The fractures are relatively uncommon, but they also occur. So one would look at whether they have joint hypermobility, they put their knee sort of bend it backwards and all the rest of it. Do they have a sclera, transcendentation, and so forth? And there's often a family history as well. I think it has potential implications for the pregnancy. Just during the pregnancy itself and during the delivery, they're at risk of hernias, etc. I don't know how relevant that is to this girl. The diagnosis of Ehlers-Danlos in her case was just not quite clear how that was made. Disturbed gut mobility can certainly be part of it. So.
Yeah, okay. Some quite interesting discussions. Do we have any other questions or comments from the audience? Otherwise, we might move into just a quick Q&A session. If anyone has any other general bone questions, they can feel free to add it into the chat and we'll try to get some answers or discussion going.
Brenda, I think you all want to get back to the Olympics.
Well, in that case, then, thank you, everyone, and especially to our experts and case presenters. That concludes our meeting for this month. Please get in touch if you have any cases you'd like to present, and we would always be more than happy to present on your behalf if that's preferred. Our next meeting will be on the 2nd of September. So have a good evening. Enjoy the Olympics.
Thank you.
Thanks, Brenda.
Thank you.